Good afternoon and welcome. I'm Dr. Sandra Hernandez, and I'm President and CEO of the California Healthcare Foundation. For those of you not familiar with CHCF, we're an independent, not-for-profit philanthropic organization dedicated to making California's healthcare system work for all Californians, particularly those with low incomes and those who are not well served by the status quo. Today's convening is one of a series of regular events we sponsor for Sacramento policy staff and other interested individuals throughout the state. The briefings are intended to keep valid information relevant to key healthcare issues and trends, and to promote dialogue on possible solutions to challenges the state of California is facing. The coronavirus pandemic has made it impossible to ignore how our current system fails to meet the needs of far too many Californians, especially Californians of color. Unequal access to quality health care has allowed the virus to cut a path of devastation through communities of color over the past year and a half. Inequalities in healthcare are rooted in a set of rules that in general are stacked against communities of color. Now's the time to rewrite those rules. An important place to start is with our Medi-Cal program. The role that Medi-Cal can play in helping the state achieve health equity really cannot be overstated. About 80% of the state's roughly 14 million Medi-Cal enrollees are people of color, and 40% of them speak a language other than English. There simply is no other healthcare agency, purchaser, or program in the state that has a greater influence in the quality of healthcare provided to Californians of color. That's why the upcoming reprocurement of commercial managed care plans is so important. The vast majority of Medi-Cal enrollees get their care through a managed care plan. But up until now, the contracts with these plans have failed to ensure that Medi-Cal enrollees get the high quality care they deserve. The rules just aren't written strong enough. Over the last 10 years, quality of care across the Medi-Cal managed care system has either stagnated or declined on many measures. The quality of care received by Californians in Medi-Cal is often much worse than those with other forms of insurance. And even within the Medi-Cal program, there are significant disparities in quality among Medi-Cal enrollees by race and ethnicity. This results, of course, in too many Medi-Cal enrollees going without proper vaccinations, as we're seeing right now in COVID, not receiving timely prenatal care, cervical cancer screening, or going without adequate care management for chronic diseases such as diabetes, obesity, and hypertension, that often make them at more severe risk for other complications, including, for example, with COVID-19 infections. As a former public health director and a longtime primary care provider working in the safety net, I know firsthand the influence that Medi-Cal managed care plans can have on patient care. This procurement process that we're undergoing provides a tremendous opportunity to rewrite the rules in Medi-Cal managed care. One of the best opportunities we have in this program are to rewrite the rules, to create new incentives where Californians can use its massive purchasing power to improve care and to help eliminate widespread inequities. On June 1st, the Department of Healthcare Service took its first major step in the procurement process by releasing a draft RFP, which outlines its requirements for health plans. DHCS is committed, in its commitment to stakeholder engagement and feedback, allowed for a 30-day public comment period. CHCF put out an open call to share with us comments submitted to DHCS so that others could read what various organizations and individuals had to say, to identify areas of common ground and understand where there might be different perspectives. Last week at the Stakeholder Advisory Committee meeting, DHCS shared key themes that emerged from the comments on the draft RFP. Today's webinar is intended to keep this important conversation going. Specifically, what did stakeholders think was positive about the RFP? What was missing? How might it be strengthened? Is the state maximizing this unique opportunity of procurement to improve care and to advance health equity? I'm looking forward to today's engaging conversation with our panel of experts and hearing your questions. There's no doubt that this procurement has the power to dramatically accelerate efforts to tackle disparities and improve healthcare quality for millions of Californians for years to come. Thank you for joining us today and for being so engaged in this topic. And now it's my pleasure to introduce Chris Perrone, who is the Director of Improving Access Team at California Healthcare Foundation, who's going to lead our panel. Thank you, Chris. Welcome.
Thank you, Sandra, and thank you for grounding us in the important context for this work and setting the tone for today's discussion. This is clearly the kind of opportunity that doesn't come along very often. The first ever statewide procurement, along with CalAIM, are the biggest opportunity to shape Medi-Cal managed care program and address longstanding disparities since the program as we know it was created in the mid-1990s. We've got a full agenda, so I'm going to jump right into it, where I'll begin by discussing the project goals and timeline. Danny, if you could advance to the next slide. Thank you. After introducing the project goals and timeline, Beth Waldman, Senior Consultant with Baylor Health, will present their analysis of the stakeholder feedback that we received. In her 14 years at Baylor Health, Beth has been working actively with states across the country to improve access and delivery of health care and advance payment reforms in Medicaid. And she's authored several reports for CHCF that draw upon her national expertise. Prior to joining Baylor Health, Beth was the Medicaid director for the state of Massachusetts, where she played a key role in the development and implementation of the state's historic health reform law, and in overseeing all aspects of the Medicaid program there, including the managed care program, which consistently scores at or near the top in terms of quality of care. Following Beth, I will moderate a panel of rock stars. They include Karen Savage-Sangwin, Executive Director of the California Pan-Ethnic Health Network. CPEN, as I suspect most of you know, is a statewide a multicultural health advocacy organization focused on eliminating disparities and addressing structural racism in healthcare. Karen took the reins in 2019 and since then has taken CPEN to new heights. I've had the privilege of working with Karen and her team for the past several years, including supporting their health equity system transformation project, which culminated in an important synthesis of what they heard from local communities throughout California and the creation of a guide for policymakers on a path to centering equity in healthcare delivery and payment reform. Also joining us for today's panel is Linnea Koopman, the new Chief Executive Officer for the Local Health Plans of California, the statewide trade association representing all 16 of California's not-for-profit community-based health plans that collectively cover over 70% of Medi-Cal managed care enrollees. Before joining LHPC in 2018, Linnea worked for the County Behavioral Health Directors Association and the LA County Department of Mental Health. And these diverse experiences will surely serve her and her members well as we strive to create a more seamless, integrated program for Medi-Cal managed care enrollees. I also want to acknowledge what many of you might be asking why this is a procurement for commercial managed care plans. Do we have the head of the Local Plan Association on our panel? And the answer is quite simple. The local plans are as invested in the outcome of this procurement as anyone. The draft contract that DHCS shared for public comment and is continued to revise will be the contract not just for the commercial plans, but for the local plans too. Also, we did invite the California Association of Health Plans and they declined our invitation to participate on the panel. Our third panelist is Mike O'Day. Mike is the Director of Health with Children Now and has been a leading voice on the problems many children experience getting timely preventive primary mental health and specialty care. We're delighted to be supporting new work that Mike and his team are getting underway to engage leaders, plans, providers, and children's advocates at the local level to examine how children enrolled in Medi-Cal managed care in their communities are faring and to develop a pathway for improvement. Children Now is one of many children's advocacy organizations that submitted comments to the draft RFP, and I look forward to learning from Mike's insights. Following our panel discussion, we will reserve 15 minutes for Q&A from the audience, and if you have a question, as noted in the chat, please type your comment into the Q&A box. We will do our best to get as many questions as we can. Next slide, please. So the project goals are quite simple. First, to listen and learn from others by soliciting feedback provided to DHCS. Clearly, CHCF has done a lot of work on Medi-Cal managed care, and we have our own perspectives in terms of the opportunities and challenges, but we wanted to hear from others and learn from the comments and feedback that they were providing to DHCF. Second, we wanted to make that feedback widely available by posting it online. So those organizations that submitted feedback, we posted it online, and you can follow links to find that feedback. We have heard from many that they appreciate the opportunity to hear what their colleagues have submitted to DHCS, and so appreciate that people sent us their feedbacks to share with others. And finally, we wanted to foster transparency and accountability by identifying and sharing the common themes, and that's what we're here to do today, is to lift up those common themes. Next slide. So the project timeline began when DHCS released its draft RFP at the beginning of June. Very rapid timeline, as you can see. Comments were due to DHCS at the beginning of July, and at the same time, we then extended that deadline by 2 weeks, which gave Bela essentially 2 weeks to develop this presentation. We're holding our webinar today. Next month or so, we will be releasing a full report. The timeline of procurement, of course, extends well beyond this, with DHCS planning to issue its final RFP and draft contract by the end of the year. Taking 2022 and 2023 to conduct the procurement and to assess operational readiness, and then finally launching these new contracts in 2024. Next slide, please. In terms of the response for our call for comments, we received 19 responses that were sent to DHCS. 15 of these are posted on chcs.org. A few organizations asked that we not post them, but include them in the analysis. DHCS, of course, as many of you heard, received over 48 responses. So we understand this is a subset. We believe that probably what we're missing most is responses that were submitted directly by health plans to DHCS. But I just want to acknowledge that we have what is perhaps an incomplete picture. On the other hand, I feel very good about the organizations that we heard from and that we have a pretty strong and healthy picture of what the feedback was. Those organizations sharing their feedback included consumer advocacy groups, provider organizations, and managed care plans and their associations. You can see the distribution here. Finally, worth noting that most responses to DHCS reflected feedback from several organizations. So while there's only, we received 19 responses, they represent collectively well over 500 organizations. One set of comments alone represented over 400 groups. So with that, I will hand things over to Beth, who will, in just 20 minutes, try to summarize the findings of their analysis of the stakeholder feedback. Welcome, Beth.
Thanks, Chris. I will say it has been a busy couple of weeks. We're a little blurry-eyed from all the analysis, and I do feel bad for the state because I only had to look at 20 of the comments, so they had twice as much as me to look at, and there's a lot there. So I'm going to talk through our approach to identifying the themes that we have called out to talk about today. It's important to recognize as I go into this that this doesn't reflect all of the comments that were received by CHCF, and it also just highlights some themes. There was not enough time to get into every aspect that we potentially could have. It's just really giving a flavor to the comments that were collected and calling out sort of what rose to the top for us. But if we haven't highlighted a comment here, it doesn't mean that it wasn't important. It doesn't mean that the state shouldn't consider it as they are revising their RFP or their model contract. I'm not going to cite specific groups in any of my comments today, but as Chris noted, all of these comments are online for you to see if you wish to do so. The other thing I want to note is we didn't look at the comments to see whether they were on point or not. We just pointed out, we're just pulling out what the comments are. So for example, there might be a comment that you see here that you know there's already a requirement in the contract about that specific comment. In most cases, the flavor of these comments is around improving off of what happens today. So even if there is a comment that seems like it's already included in the requirements for the state, many times commenters are really asking for something either to be clarified, improved upon, or having plans held to it at a higher standard than they are today. So we have grouped into 3 major domains that we're going to talk about: the completeness and clarity of RFP, access, quality, and disparities, and payment and partnership. So with that, let's move to the first domain, and that's the completeness and clarity. Here, there are 3 main topics that we're gonna focus on: releasing a complete draft of the RFP for review and comment, ensuring that the contract reflects full scope of managed care plan obligations, and clarifying the managed care plan requirements. So in terms of releasing a complete draft of RFP for review and comment, many commenters were concerned about gaps in the draft procurement documents that were put out for public comment. And they were concerned that there wasn't going to be a second round of review for them to comment on any further changes to the document before they became final. That's the first thing. The second thing is many commenters that we reviewed had some suggestions about what the potential RFP evaluation questions could be and what the scoring could be. So for example, one commenter suggested specific evaluation scoring of plans based on quality performance on particular measures like wellness visits for children. That kind of detail isn't in the draft RFP at all. There's not evaluation questions for people to reflect on, but many did give DHCS some food for thought in terms of what those topics might be. People also commented on missing information, CalAIM, additional equity requirements, schools and youth behavioral health programs. We know these new requirements are out there. They're just not necessarily in the RFP or model contract as it stands today. By releasing its draft RFP and model contract, the state is really joining a new trend in Medicaid managed care procurements, where states are putting out draft procurements for review. Historically, states would gather stakeholder feedback, but not necessarily in this way. There would be lots of pre-conversations with stakeholder groups and perhaps a request for information. But the fact that the state is released an RFP for review and comment really does speak to the fact that they're interested in getting feedback from all of you and really following in the footsteps of many of the recent procurements of states that have done that as well. So next slide. As many of you know, in California, a lot of the requirements and guidelines for the plans are included in all plan letters. And there were a number of comments suggesting that these all plan letters be incorporated into the model contract for plans. There also was a number of comments that selected areas of the contract where there were requirements that seemed to be missing. Again, some of these comments are on new initiatives that might not have gotten into the contract quite yet. As Chris noted, this contract goes live in January of 2024. So there's quite a bit of time between where we are now and where the state will be when the contract goes live. So there is more time to put in some of these details. But there's other things that that seem to be requirements today that people didn't see in the contract that was released. So some of that could be because the detail is in the all plan letters, and some of that could be because the drafting of the contract is continuing. But there were a number of examples, and we have some here about what people didn't see as included. I will say that many states, as they're putting their model contracts together, do not have all of the detail that some commenters are looking for. Many states give some broad outline of what they expect for their managed care plans within contracts, and maybe some methodology for how to get to things, but leave some flexibility within their contracts for exactly how you're going to achieve specific requirements of the procurement. And some of that is filled in through other detailed guidance like you have in all plan letters, and some of it is left to the managed care plan to figure out themselves. And I think part of the tricky balance for states and stakeholders is what kind of detail you really want to have in order to ensure that you're getting what you need from your contractors, but at the same time giving both the state and the contractor some flexibility, because you don't know everything that's coming around the corner, and you don't want to be too black and white about everything and not be able to expand on some of what you're doing. So next slide. This slide is really an example of some of the comments that we reviewed that looked to the state to clarify some of the managed care plan requirements. Here, this is around care coordination. There were several other examples that we could have pulled from, but this just gives you a flavor of the kind of comments that we're hearing when we're looking at these comments. There were lots of questions around care coordination and how it could be clarified, and where there could be some more detailed requirements for the plans. Next slide. So now we're going to head into our second domain, which is around access, quality, and disparity. Not surprising, there were lots of comments focused on these areas, looking at access to care, quality, and addressing disparities across the Medi-Cal population. And so here we're going to highlight 4 of these areas. So next slide. The first slide, the first topic here is around enhancing requirements for managed care plans to have adequate networks and timely access to care. There were many comments around network adequacy, and that's not a surprise. There are a fair amount of requirements today in the contract around network adequacy, but many commenters were looking for additional oversight from the state to ensure appropriate access for beneficiaries, including that where network adequacy standards need to be waived and an alternate put in place, that plans meet requirements for coverage of transportation and out-of-network providers. There was some commenters noted that there are, that because there are so many alternate standards that are put in place and approved, it's really difficult for beneficiaries and advocates to understand really what the standards are, for example. So on the next slide, we see that the second topic is around holding plans accountable, more accountable for performance. So not to say that they're not accountable today for performance, but trying to do more to tie plan payment to performance. And ensuring that there's value and accountability. There were several comments focused on requiring plans to meet the 50th percentile of performance on benchmark measures and tying those payments to performance as well. Next slide. There were many comments focused on holding plans more accountable for reducing disparities. As Sandra noted in her opening, reducing disparities is a place that many of us are focused these days. And so having so many comments here was not a surprise. It is important to note that commenters really stress the need to look broadly at disparities, not just racial disparities, but looking at subpopulations to see where there's disparate outcomes that really could be improved upon. And some commenters suggested requiring plans to set year-over-year targets for elimination of disparities over time for both physical and behavioral health care. Next slide. There also were many suggestions around enhancing requirements related to culturally competent care. And of note, many were appreciative of the state's requirement or intent to require the NCQA distinction of multicultural care by 2026. But there were lots of concern that it'll be overly burdensome, particularly for smaller providers, and that this requirement could actually lead to some trouble around network adequacy if providers decided that it was too burdensome and they couldn't participate in the program because of it. Next slide. So our third domain is payment and partnership, and here we're looking both at the appropriateness of the funding for the Medi-Cal program, as well as partnering with community-based organizations. So there's many comments here, and we're going to touch upon a few. So next slide. In terms of payment, you can see here I've got three slides full of payment. But the bottom line here is that many commenters noted that there were a lot of new requirements within the model contract, and that it was important that both plans and providers be appropriately compensated for providing these services. There was comments around payment for telehealth, around payment for emergency transportation, making sure that child serving providers' rates were sufficient. Next slide. A number of comments focused on supporting providers through incentive programs and moving towards value-based payment models. There also was a recognition that if providers were going to succeed in these value-based payment models, that they would need some technical support and financial resources to help transition to different payment and delivery system models. Next slide. And then finally, in terms of payment to providers, a number of commenters stressed the importance of primary care in ensuring that there is the appropriate use of and spending on primary care. And these comments here are focused on reporting relative to the level of primary care. Next slide. In terms of requiring managed care plans to support efforts to address social determinants of health, there was a lot of focus on having strengthened approach to addressing health-related social needs of beneficiaries. And the comments ranged across many different aspects of the program, including adding new types of providers and benefits, improved training, data collection, and public reporting. Next slide. A number of commenters focused on the treatment of youth, including some of the examples here around training for adverse childhood experiences and conducting ACEs screenings, partnerships for community-based organizations focused on youth. Next slide. There was lots of focus also on having a local presence for plans and to be engaged in the community served. Here, there was some focus on plan spending of their minimum, their medical loss ratio on non-clinical services in coordination with community-based organizations. Next slide. And again, there was comments around specific investments in the communities being served. So investments in the safety net, investments in behavioral health, investments in community wellness and equity funds. Next slide. And finally, this is a little bit of a repeat in that, again, there was a lot of focus on primary care and making sure that it's the right amount of spend, and that there's focus on these clinical, non-clinical services in coordination with community-based organizations to address social determinants of health. Next slide. There are also a number of additional comments that we heard of note that we just call out here. Some on additional stakeholder engagement focused on the reducing of the number of plans in San Diego and Sacramento, clarifying that a diagnosis isn't needed for children to receive services in schools, expanding the use of the deemed credentialing process. Next slide. Identifying and addressing bias in risk stratifications and algorithms, really focusing on making sure that there's complete, accurate, and timely encounter data, and considering whether audit requirements are overly burdensome to managed care plans. This is just a smattering of the other comments that were received. We just wanted to give a flavor for some things that didn't necessarily jump out into themes, but did jump out to us. On the next slide, we wanted to acknowledge that there are some cross-cutting comments or topics across the different areas that otherwise didn't specifically rise to a theme, but we wanted to really pull out. To note that many commenters noted that plans must be required to support access to high quality behavioral health services and maternal and child health care, and invest in care for children across services and providers, including in schools. And so while these things we didn't identify as specific themes, they really did cut across a lot of the comments that we received. Okay, so I think I'm going to be on my last slide and let you get into the panel. But just in conclusion, there were so many great comments that were received, and it was really clear that commenters appreciated the ability to provide feedback on the draft procurement documents and would love more ability to do so. And the feedback that was received was very thoughtful. It was on a wide range of issues, and DHCS will certainly be taking that into account as they finalize the procurement. So with that, I'm going to turn it back to Chris.
Wow, thanks, Beth. That was really a tour de force. Thanks for getting through all of that in just a short amount of time. And just want to acknowledge that we did have limited time for this presentation of findings and for the discussion overall. So if you have follow-up questions to the information that Beth presented, please do add a comment in the chat to let us, or excuse me, add a comment into the Q&A that you would like to hear more about something. Okay, so with that, I'd like to invite the panelists to join me, Karen and Linnea and Mike, and remind you to take yourselves off mute. Great, good to see you all, and thanks for participating today. I'm going to start off with a question for all of you, and maybe Karen, I'll ask you to answer first. But Beth covered a lot of territory. There's clearly a lot of themes that rose to the top. We thought we could narrow it down to the top 10. As you saw, Beth presented 12, and then we stuck in some others to these additional comments. I'm curious what you think were sort of the top themes that resonated for you. Which were most important to you that you would want to underscore by sharing your perspective?
Sure, thanks, Chris. And Beth did an excellent job, I think, going over a lot of themes. And I was pleased to see, I think, some alignment in a number of the comments, particularly around the issues of health plan accountability and how the department could have used this opportunity to strengthen accountability for health plans, both through how we pay health plans and how we measure what they're accountable for providing beneficiaries. And for us, that is specifically about racial disparities in healthcare, right? Which are, I think, continue to be alarming and should concern all of us. And so I think this is a missed opportunity for the department to lay out more of a strategy around how we really can have a greater level of oversight and accountability, as well as engagement with consumers and communities to determine what's going well and where we need improvement.
Great, thank you. Couldn't agree more. Mike, I'm going to ask the same question to you. What really jumped out at you and really resonated with you that you'd like to underscore from Beth's findings?
Yeah, thanks, Chris. In addition to agreeing with Kieran about a vision for accountability and disparities reduction, I think I was really struck by the number of comments about kids. I think that just reflects what we know about what kids need in terms of healthcare, particularly preventive healthcare, where kids are. Sometimes they're at school. And also that we know that performance is really bad for kids. Like, I can't put it any other way. And so I think these comments reflect that the draft RFP doesn't actually change anything in the poor performance for kids. So I was really struck by that kind of cross-cutting issue that wasn't a theme, but still cuts across.
Thank you, Mike. And Lene, I'm going to ask you the same question, but before I do, I just want to acknowledge and appreciate that you are here with us. We've got a couple of consumer advocates here, and as you and I have talked about, the managed care plan perspective is so important, and that we would have felt that this was a missed opportunity if we didn't hear from the managed care plan perspective. So I just want to really appreciate you for joining us today and offering your perspective. So same question to you. What among the themes that Beth discussed, what really stood out for you? What would you like to underscore?
Sure, and thank you for having us. I'm really pleased to participate this afternoon. So before touching on one of the themes that really resonated for me, I just want to underscore the importance of this process and this review process of the draft RFP and draft contract. It's really critical that we get the contract right. It's a core document that really implements the vision and the future of Medi-Cal in the coming years. And this is also the first time in many, many years that there's been a complete overhaul of the contract. So while not only are we adding new requirements based on the priorities of Medi-Cal program, we're also reviewing it for outdated requirements or duplicative requirements. So I think just kind of through an overall lens, this is a really important process that we're undertaking here with the department. And I think that leads me to, the theme that resonated for me, which is the completeness of the draft MCP contract. And we think that it's really important that DHCS have a transparent and collaborative process to review the draft contract in its entirety and not just the components that were shared with us in June. Of course, there was a lot in that draft RFP and draft contract that we reviewed, and a lot of new requirements, a lot of, I think, exciting opportunities in there through the contract and what's proposed in there, but also a lot of important things missing. CalAIM, enhanced care management, and ILOS, population health management, the variety of new programs and services included in the Children and Youth Behavioral Health Initiative passed in the budget this year. And I think I could give a number of other examples. And so I think although DHCS has indicated that, they'll have plan and stakeholder feedback through the policy process and development of APLs and guidance outside of the contracts, I don't think that's a replacement or a substitute for a full review of the draft contract. So I think that's the theme that resonated with me, is really urging for a transparent and additional process before that final RFP is released later this year.
Thanks, Linnea. I want to pick up on that point maybe for all of you and just acknowledge what you said, which is that DHCS has said this is a process. This is in fact, we're essentially at the beginning of a 3-year process in which the contract's actually go into effect in 2024, and the contracts will continue to evolve not only in response to the feedback to the draft RFP and contracts, but also in response to changes in federal and state law and emerging priorities that DHCS establishes between now and then. And still, as you said, Linnea, it's important that that people see the benefit of having this all together as opposed to parts of it in our draft contract, and you have to go look over at past APLs to get the other part of the picture. So let me just, again, picking up on your point, and again, maybe starting with Kieran, when DHS releases its final contract, I want to focus on the contract right now, or actually, let me broaden this. When it releases the final RFP and the contract, what are 1 or 2 things that you most want to see addressed there? You talked about vision earlier. Is that the thing that rises to the top, or are there 1 or more other things that you'd really like to see in that next iteration?
I think I'd really like to see a more concrete strategy for eliminating racial disparities in the program. I think that we know that the disparities are extreme and unacceptable. But what we don't see in the draft RFP is really the plan. We see a commitment for doing something about it, but what we don't see is a specific strategy. And so I would hope that the final version will really outline some of what DHCS can and will do around reforming how we pay health plans. And we'll also outline a process for getting us to a set of measures on health equity and disparities that will be effective for driving better performance. And I understand that those measures maybe shouldn't be set in stone in a contract, but there should be a process that allows us to sort of set forth the domains that we'll be looking at, how stakeholders and consumers will be engaged in a process alongside plans and providers to determine what are those things where we are really trying to drive change and how will we evaluate them.
Great, thank you. Mike, same question to you. What would you be looking for? What are the one or two things you were looking for most in that next iteration?
Yeah, I'm definitely going to be looking at the payment rate setting piece. I do think it needs to be tied to some outcomes that we want to see, and right now it's not. What DHCS has proposed is not, hasn't done that yet. And there's a separate Cal-Lane regional rate setting proposal that we don't know a lot about, but when DHCS has talked about it, they've talked about it exclusively around cost efficiencies, not around quality improvement. And so that really worries me that the financing payment discussion seems to be completely separate from this goal of quality improvement that seems to be sort of talked about, but not actually embodied.
Thank you. And Linnea, back to you. You raised this concern to begin with. What would you offer here in terms of the things that you're most looking for from this next iteration?
I mean, I think it's all of the issues that I mentioned, but I think, perhaps calling out one in particular are the requirements and more details around some of those specific programs in the Children and Youth Behavioral Health Initiative. I think we've been talking about Cal-Lane for a long time, and there's a lot of details still to be fleshed out, but I think kind of what's expected there is more known. Whereas, a lot of what it was included in the budget for the Behavioral Health Initiative was just introduced in May, and we really don't have any details about not only the implications for the programs that plans will either be directly overseeing or the services that will be newly responsible for delivering, but also how all of these components fit together, including, how we'll coordinate and kind of connect the dots between programs that others, including counties or providers, may be responsible for delivering through that program. So I think that would be the one area that may be of most interest, but I would still go back to the initial comment of I want to see all of those pieces, before the final draft's released.
Great, thank you. There has recently been increased attention on the role, and this is, Kieran, this is a question for you. There's recently been increased attention on the role that Medi-Cal can play in terms of advancing health equity and addressing longstanding racial disparities. And we've heard some really, I think, welcome comments by Director Lightbourne and others and his team at DHCS. And they've indicated that advancing health equity is a key goal in this procurement and for their work more broadly. In what ways do you think that this draft procurement document and the draft RFP really embrace that? And what are 2 or 3 other ideas that you're advocating for?
Sure, thanks, Chris. And so I think we sort of sum up the health equity focus in this procurement as better but not good enough. And so just to kind of level set where we are at with our Medi-Cal program, people of color, including children, are less likely to have a usual source of care, less likely to receive timely and effective preventive care, and more likely to have poor health outcomes, whether it's poorly controlled chronic conditions, serious behavioral health conditions, or less satisfaction with their health care. And there is a significant focus in here on social determinants of health, which I think is a good thing. And these are definitely things that impact health. It is also true that healthcare and how the Medi-Cal program performs are major drivers of inequities. And so when we look at this procurement, I would say on the positives, right, we definitely see, I think, new leadership from the department that is strongly indicating that health equity is a key priority. So there's a new requirement that every plan have a health equity officer. There's a requirement for a quality improvement and health equity advisory committee. There's sort of revamped requirements for annual diversity, equity, and inclusion training, right? There's new reporting requirements around what the plan is doing to provide culturally and linguistically appropriate care. I talked a lot earlier about how the procurement does not go far enough in terms of accountability, but I will say DHCS has included language to give them the opportunity to go farther on accountability, right? So I think that's a welcome signal from them. And then the third thing I would say that we think is good is there's really an acknowledgement here about the crucial role of consumer input and local engagement. And so there are a number of things that have been done to strengthen the role of the consumer advisory committees, including reviewing the population health assessment findings, discussing improvement opportunities. So really looking at those committees as a place where there should be a robust forum that informs how the plan operates. So those are things that I think are welcome and that we want to embrace. But I would also say, I mean, really going back to, we would like to see a much stronger vision, concrete targets, requirements for year-over-year improvement in disparities reduction. These are things I think that are very doable and without which we won't get where we want to go on equity. The other piece I would point out is something that's really important for us that we feel like is somewhat weak here is the approach on behavioral health. And Linnea talked a little bit about what's missing. But I also want to highlight, our health plans are responsible for providing significant behavioral health services, particularly to folks who are having sort of intermittent behavioral health needs, less severe behavioral health needs. And what we've seen since that went into effect in 2014 is that almost nobody is getting those services. And particularly people of color are not getting behavioral health services from their health plans. And so we would like to see some stronger requirements in the contract around what health plans need to do to deliver behavioral health services in a manner that's really equity focused. So informing their providers. We've found that primary care providers don't know how to refer people to behavioral health services, right? And doing a lot more outreach to their members to really have people understand that they have a right to get behavioral health services. This is what's available and this is how you access it, again, in a culturally and linguistically appropriate manner.
Thanks, Karen. And I maybe just want to underscore what I think I actually hear from each of you, which is that we are all very appreciative of the fact that DHCS has taken these steps to put out the draft procurement and draft RFP for public comment. We see tremendous progress in terms of what they've already put out, but there are opportunities to go further. And I think we're all anxious because this is such an important opportunity, and we've been waiting for so long to really address these longstanding disparities and challenges in terms of providing seamless care for beneficiaries that we're anxious to get into the details and hear the complete picture. So Mike, I'm going to turn to you, and you touched on this a little bit in your opening remarks in terms of the overwhelming response from children's organizations and why that's significant. But I'm wondering if you could just sort of expand on that. As I mentioned in my opening comments, we had one set of comments from over 400 organizations. I imagine that was a significant undertaking to get everyone on the same page there in terms of those comments. Can you say a little bit more about why you see this procurement so important for the children in California?
Sure. Just taking a step back, there are 5 million kids in Medi-Cal that are enrolled in managed care. That's 92% of the kids in managed care. So it's most kids. Kids also have a unique benefit, EPSDT. They also have unique healthcare needs. Everyone knows a kid should go to their annual checkup, and yet only 50% of kids in Medi-Cal are getting that annual checkup. So that's kind of like the most basic thing. And I don't think it was actually really hard for people to understand that. And if kids are missing out on those basic well child visits, they're also missing out on their immunizations, on those screenings, on those referrals, both to behavioral health services, but also to dental services. And so there's just a lot of disconnects. And yet we see things in the contract like medical home. What does that mean? A dental liaison requirement. What does that mean? basic care management that provides the wellness and prevention services that we know most kids are just going to need just for being kids. How does all of that fit together? And there was no vision. There weren't even actual, we don't actually even know what a dental liaison is. It was just in the contract, the draft contract once. There's no guidance on it. So I don't really know how one would actually, begin to operationalize that as part of this contract without that sort of guidance and clarity. So those, I think, when we explained that to our partners, they understood like that doesn't make sense. So I think people understood this issue and the impact on kids pretty directly. So I guess that's what I would say.
Thank you, Mike. Linnea, last question to you before we open things up to the Q&A from the audience. The draft contract, as we know, includes many, many new requirements. And I'm interested in your perspective on which of these you think are maybe most important or have the most opportunity to be transformative. And are there any that you and your members are particularly concerned about?
Yeah, so I think we've clearly seen over the last year or two that there's a vision for transformation and access and quality and equity, through CalAIM and other proposals put forward by the department. And so I think, it's really important, as we've all reiterated today, that the draft contract reflects that. And I do think, one area to highlight that we think has the potential to be transformative are the requirements pertaining to quality. But I think the details of how we get there are really important. And, I think there are some key details missing. And so I think with regard to quality and kind of that how, as I mentioned, I think, to meet the ambitious goals that are outlined in the contract, which, are ambitious, I understand the push to go further and for more specificity. But I think that, another one of the themes that was mentioned by Beth earlier was how to tie payment to quality. And so while we've heard DHCS's commitment to holding plans accountable to the minimum performance level and imposing sanctions and corrective action plans, we haven't heard their vision for how they will connect quality with managed care plan payment. So since DHCS announced its new quality framework a couple of years ago through the managed care accountability set, we've really urged the local plans have really urged the state to consider not only punitive approaches for lack of performance, which ultimately results in fewer resources to our providers and in the delivery system, but also to include approaches that reward achievement and improvement. So to that end, we'd encourage DHCS to consider establishing quality incentives rather than other approaches like withholds. So I think that's one area that has the potential to be transformative. And I think another consideration when we think about quality, and I realize this is a big one, but is workforce. It does contribute to the ability to meet quality performance targets and measures. And so I think we can't look at any one of these things in a silo, but look more broadly at the systemic issues that really contribute to quality performance. And then to just briefly speak to your the second part of your question around any specific requirements that are worrisome. I wouldn't call any one requirement out, except to say that I think the cumulative impact of all of the new requirements are something that we're really hoping the state kind of evaluates from a holistic perspective, meaning that we ensure that there's proper resources to actually be successful in implementing all of these requirements. So I think it's a matter of ensuring that the vision and the contractual requirements and then the rates and resources to support implementation are in alignment. Chris, you're on mute.
No one can hear you.
Oh, thank you. Sorry. I'm going to want to thank all of the panelists. And we're going to move to the audience Q&A, and I want to invite Beth Waldman back onto the screen. Thank you, Beth. So one of the things that Beth touched upon in her in the section on sort of other comments was the proposed actions that DHCS would be taking in Sacramento and San Diego's to reduce the number of commercial plans that would be operating in those counties. I know CHCF has done some work in this area, demonstrating that in those counties where there are more commercial plans, there's no evidence of higher quality, and we know that there's it creates some challenges in terms of beneficiary navigation. But that being said, I'd love to hear from our panelists, anybody who has a perspective on this, pros and cons about the proposed reduction in the number of plans. Would anyone like to take this question?
And I can jump in, and I know Mike has thoughts. But, you know, I'll just say, I think in general, we think it's probably the right direction. As you said, we haven't seen higher quality in those two counties with the number of plans. In fact, we see some really poor performance from several of the plans in those counties. So we do think there's potential for there to be better care with fewer plans and to reduce churn as well as confusion among enrollees and providers who are dealing with quite a few plans. We would, though, however, sort of advocate for more robust stakeholder engagement around exactly how that is done, how many plans, et cetera, because those two counties do have some pretty unique needs. And so, and it would be a significant transition. And so we would like to see some greater and specific stakeholder engagement around that decision.
I would absolutely agree with everything Kieran said. And also just say there's kind of a fine line between the competitiveness of the market and then all of them just kind of looking the same and race to the bottom. I also don't think that DHCS has a great way of expressing to families the difference between plans when they're choosing a plan. So I'm not sure from a consumer perspective how to really know the difference. And if you're looking at provider directories to see if your doctor's in that network, there may be issues with the provider directories that are unreliable. So I think, you know, all of those need to be part of the consideration.
And I think that the only thing I would add is, you know, I think we anticipated that there would be a reduction in the number of plans, but not necessarily going to just 2 plans. I think that was a surprise to many of us. And so I think, you know, there should be a consideration also for ensuring that there's no disruption in such a drastic change to members. And then also, I think, you know, really looking at, and I realize this is, you know, the intent of the RFP process, at the plans that, you know, have high quality scores and are embedded in their local communities today as a significant consideration in that procurement process.
Great, thank you all. The next question is about network adequacy. So actually builds on some of the comments that I heard from Mike there. And the question is posed is, how can plans maintain their network adequacy when only half the docs in the state take Medi-Cal? And maybe I'm going to start with you, Linnea, and ask maybe just your perspective on this challenge that the plans face in ensuring adequate provider networks. And also, I think that this maybe triggers for me this just the question of what else beyond the Medi-Cal managed care plan can beyond the managed care program can DHS be doing to bolster physician participation in the Medi-Cal managed care program?
Yeah, so I think that's a good and challenging question that probably there's multiple dimensions to it. But I think a couple of things come to mind. And I think, again, it's looking at this issue holistically, which is looking at how do you get providers into your network and what's been successful in bringing providers in and then retaining those providers. I think that's equally as important. And I think, you know, we've seen the value of some of the Proposition 56 payments and kind of retention or, you know, strategies or a way of bringing additional providers in. So I think, you know, that's, I think one consideration. Another, I think, is just looking generally at the Medi-Cal reimbursement rates in our state relative to other states. That's something I know that has been highlighted in previous reports and other places as an issue or a challenge. And then I do think also, it's a workforce pipeline issue. And I know that there's a number of investments that are occurring today and are proposed for the future, but I think that is an area that we really can't lose sight of. I realize it's not an immediate fix. Workforce development takes time, but I think it's really critical when we think about the future of the Medi-Cal program and ensuring that we have sufficient providers, particularly as the Medi-Cal eligible population in our state continues to grow and expand.
Thanks, Linnea. Does anybody else want to take that up before I move to the next question?
Well, the one thing that I would add is, I think, really embracing and leveraging a team-based approach, and that there are some changes outside of this procurement in terms of bringing community health workers into the Medi-Cal program, bringing doulas in, right, that I think are really important, and that I also would really urge the department to have a very thoughtful, intentional process around how those happen, because those are provider types that have the potential to really expand reach, but also to really improve care, particularly for consumers of color. And so I think there's going to need to be a lot of thought into how do we make those providers part of a system that isn't necessarily set up to embrace community-based providers, right? And how do we sort of take the best of all worlds and have a good outcome for consumers?
And I would just add that in its 2019 report on children's preventive services, the auditor had a recommendation to the department on looking at some of these workforce gaps, and the department declined to implement that particular recommendation, saying it was not really in its jurisdiction. So I think there's a lot more maybe that could be done.
Thank you. And Karen, actually, you anticipated my next question in terms of both the diversity of the workforce, both in terms of the types of people that we're engaging in the care of Medi-Cal enrollees, but also the makeup of those providers in terms of their race, ethnicity, language, gender, and other characteristics as well. One of the themes sort of in the other comment section that came up, and I think is related to this question about networks, is the issue of telehealth. And I think you all know that we've done a fair amount of work in this arena. And we've seen the department really embrace telehealth, particularly in the context of behavioral health. And I might, including in their latest initiative around children and behavioral health. So maybe starting with you, Mike, to ask you what you see as the opportunities there to really advance our efforts to address gaps in care and disparities through telehealth, and what, if anything, concerns you there?
Yeah, I mean, I think there's great opportunities that we've seen, but I think it's important to recognize that it's not going to work for everyone, and it's not a complete replacement. So we can't say that there are adequate networks of behavioral health providers just because there is a subcontract with a telehealth provider. Children and youth sometimes need more. It also raises equity issues around access to the right technology. I think it's worth more of a robust discussion, but I don't think we can just look at it as a one-for-one replacement of networks, particularly for behavioral health.
And Karen, you conducted a pretty large survey of Californians on their experiences with telehealth. I would want to invite you to share some of the findings there.
Yeah, sure. I mean, I think in general, we found really high satisfaction with telehealth among people of color. I think we were pleasantly surprised by that, but several of the barriers that Mike mentioned were, I think, really, we heard those a lot in the survey. So both the sort of digital divide issues, which was not only broadband, but also cell phone minutes. We heard a lot about that. We also heard people's concerns about their privacy, and we heard people's concerns about language access. which was an issue that was surprising to us when we're thinking about how technology can solve problems, that maybe that would be one of them, but we actually heard even probably greater concerns about language access and not getting an interpreter. So I think there's some significant things that need to be worked through so that the implementation of telehealth can be equitable. And I would agree with Mike, we cannot view it as a replacement, and consumers always have to have a choice. I would say the other thing that we found that was really interesting was that there was a lower satisfaction among people who reported using telehealth to meet their behavioral health needs. And so I think there is both a lot of opportunity in behavioral health, but I think we have to be careful about how it might change the relationship, right, between a consumer and a provider, and what we can do there, again, to leverage technology where it makes sense, but also to make sure to preserve other options for consumers.
Thanks, Karen. And Linnea, do you have any thoughts on this you want to share before I move on to the next question?
I mean, I think Mike and Karen hit on, I think, the key issues. I mean, we hear also about the broadband access issue being huge, and I know it's something, that's being discussed at a statewide level, and agree in terms of the strides that we've seen in the growth of telehealth over the last year and a half, and wanting to retain that infrastructure and continue to expand it, but that it in and of itself, it's not a solution in its entirety in terms of solving some of the challenges that we have today. But it's certainly something that I think should continue to be leveraged.
Thank you. So a couple of the questions that we received relate to submitting feedback. And so maybe I will take these questions, actually. So one is, if you are interested in submitting your feedback that you've already provided to DHCS to us and having it posted, we will certainly accept that and post it. We are unable at this point to include it in the analysis, but we would be delighted to share your feedback that you've already provided to DHCS with others. There was also a related question, which is it too late to provide feedback to DHCS? The comment period is closed, so I can't speak to what exceptions DHCS is making there. Or make any promises. Beth, I want to this is maybe a little bit of a curveball, so put you on your feet here. That relates to this kind of notion of building and flying a plane at the same time, and it's come up here in the questions in terms of Cal-AIM, where Cal-AIM is still evolving, really an important new innovation in Medi-Cal program, and here we are at the same time trying to create the structure and the scaffolding for the next iteration of our Medi-Cal managed care program. And Cal-AIM really being an example, but a very important and large example of the changes that we expect between now and the time that the procurement is finalized and those contracts are finalized and launched in 2024. So just as an experienced Medicaid director, how do you navigate that? And how do you navigate it in a way that is allows you to get your job done, yet invites the kind of thoughtful input from stakeholders that we're receiving today?
Yeah, I think that's a great question. Thanks, Chris. I think Medicaid programs are often building and flying at the same time. It's just sort of the nature of the pressure on Medicaid agencies, especially over the last several years. And I think that's why it's important to allow there to be some flexibility within your contract. So again, the draft contract that's out now in 2021 is pretty far away from 2024 when it's going to be effective. So Cal-AIM is just one example. I think it's important to anticipate in the state's questions to plans how the plans will work with the state to implement Cal-AIM and the ideas they have and their commitment to it, and have enough language in the contract that holds plans accountable for implementing Cal-AIM with the state, but gives flexibility to everyone, the state, the plans, providers, and consumers to really understand what it is and not get too tied down into exactly how everything gets done now, because you just don't know. And that's why it's important to have some flexibility around what's in the contract. And maybe there's some pieces of CalAIM that are appropriate for an all plan letter. I recognize that, you want more in the contract so that you can be clear about that. And when you know what the requirements are, it's important for them to be in the contract. But where you don't know, having the ability to have another way in, while appropriately being able to compensate plans and providers, will be important for the state. So I think having the flexibility in the contract, but being clear in your questions, what your intent is. And I think Mike mentioned this in his comments, that in the procurement today, there's not really an overall vision for what the state is trying to do with the procurement. And that will be really helpful in the final say, to be clear what CalAIM means and how it interacts with this as a whole. So, because clearly it's an important piece of how the Medi-Cal program will be going forward. And so I think adding it into the draft RFP will be essential, but recognizing that when this procurement comes out in a couple months, you're still not going to have all the answers. So make sure to leave yourself some flexibility to add that into the contract at a later point.
Great, thanks, Beth. And one of the things that the department mentioned in their presentation at the Stakeholder Advisory Committee meeting was that they would be coming out, I believe it was this fall, with a comprehensive quality and health equity strategy. So I know we all are looking forward to that and the opportunity to provide feedback on that as well. And ideally to see that then integrated with the procurement and the contract. So I think that is one of these, yet another very important step in this process. So we're out of time for the Q&A. So again, I want to thank all of the panelists for joining us today and offering your perspectives and insights to this really important discussion. Thank you all again for taking the time to join us today. And Beth, for preparing your thoughtful analysis on such a quick turnaround time, and we look forward to the final report. In closing, as Sandra said at the outset, the COVID-19 pandemic has really laid bare the problems of racism in our society and inequalities in our healthcare system, and it's really time to rewrite the rules. And there's really no better place to start than with Medi-Cal. Recent reports, Mike referenced some of them in terms of the state auditor findings on preventive care for children in Medi-Cal managed care, and some of our own work showing trends in quality over the last decade in Medi-Cal managed care, really provide further clarity in terms of the work to be done and the motivation for change. And we really applaud the steps that DHCS is taking, and as I said earlier, and we've heard from our panelists, encourage them to go further. To that end, I want to thank all of the organizations, not just those here, but all of the organizations that submitted feedback to DHCS and shared it with us so that we could post it online and everyone could examine the feedback. I want to remind people that we do have this issue brief of the findings forthcoming, and Beth and her team will expand on what she's shared with us here today. Also, after we close up today's webinar, there will be a pop-up with an evaluation. We know there's a proclivity to close those pop-ups when they come, but I want to ask you to please fill out as best you can that evaluation in terms of your experience with today's webinar and your ideas for future topics. And then finally, to thank Kieran and Linnea and Mike and Sandra and Beth once again for your participation today, and all the participants for joining. Thank you and have a good afternoon.